Well, here we are. We're back again. We're going to do a take two here. We sort of cut off at the middle of everything here, and I'm being willing to bet this is probably going to happen again because it's for something. There's a glitch in the screen, and oh, maybe not. Maybe not at this point. So we're running. It cut off here. We were talking about the inner layers of the GI tract, mostly the intestinal layers. And if we look here, the inside layer is called the mucosa. Okay, and sometimes it's called the lamina propria because what happens is very thin, loose connective tissue on that inside layer. It has to be relatively thin because some things are going to be absorbed through this layer. So in other words, I have to be able to get something in through this layer, so it has to be a nice thin layer. So that first layer would be called the lamina propria or the mucosa, inside layer. We have a layer that's just inside that, that's the second layer, and the second layer is called the submucosa or the submucosal layer. Okay, and this actually has a layer of a number of nerves in there. Okay, and it's called the Plexus of Meissner. And this Plexus of Meissner, or these nerves, what they do is they stimulate the release of various secretions that will go inside the lumen of the bowel to be able to help in things in regards to absorption and stuff, or in regards to digestion, how to break things down. So that would be that submucosal layer with the nerve supply in there that will allow secretions to be released for further digestion and stuff. The third layer I have is basically called the muscularis, okay? And this muscularis also has a neural input from it. It's called the Myenteric Plexus or the Plexus of Auerbach. I don't think you have to remember all those special names. What happens is this muscular or the muscularis is there because what it does is it actually causes what that squeezing motion that we talked about. And that squeezing motion that we talked about, propel things through the GI tract, is called peristalsis. Peristalsis. So this peristalsis is stimulated by this by the Plexus of Auerbach, the Myenteric Plexus. They will squeeze sequentially to allow things to move and move things along through the GI tract. The outer layer is called the serosa, and the serosa is basically the layer, just like the peritoneum, that covers the rest of the body cavities. It's sort of, the peritoneum wraps around all the loop of bowel, and just like everywhere else in the abdominal cavity. Okay, so that would, what doesn't see where it goes to, but that's just the outside layer. It's called the serosa. So the inside layer of the mucosa, basically thin enough to get things through and loose enough to get things through that inner wall. The submucosa, which basically has a neural input to help to force the secretions of various enzymes and things like that that have to be used for digestive purposes. The third layer, the muscularis layer, which basically has nerves that will supply the nervous impulse that will allow that peristalsis or that wave-like action of the intestine occur. And the fourth layer is basically the outer layer or the serosa, which is the same thing as the peritoneum that produces that covers all the other organs inside the abdomen. Okay. When I talk about the GI tract again, probably we go back to our good old friend that we've talked about from the very beginning of the year called the peritoneum. And that peritoneum is basically a serous layer, serous membrane that lines not just all the organs inside the abdomen, but also the inside wall. And what happens if you cut open the abdominal wall, the inside wall, inside all the muscles, is this membrane that goes all the way around. It also covers the inferior surface of the diaphragm, goes all the way to the back of the abdomen. Finally, when it's to the back of the abdomen, it sort of like folds over on itself and comes forward. Right where the aorta comes down, as well as where the inferior vena cava goes up. The aorta is slightly to the left of the midline on the vertebral area, and the vena cava is slightly to the right of the midline over the vertebrae, where the inferior vena cava would be coming up. So both of these are stuck against the backside of the abdominal wall by the peritoneum, and therefore they are also called retroperitoneal. Now there are a number of other organs that are called retroperitoneal. Retroperitoneal just means that they're stuck to the backside of the abdominal wall, such as the kidneys. The kidneys don't flop up and down, they don't move back and forth, but they're stuck to the backside of the abdominal wall, and they have a little bit of excursion because they have to move up and down, like with the liver on the right side. But basically, they're relatively fixed in position. Other connective tissue and fat will hold them to the posterior side of the abdominal wall, and then covered over by this peritoneum. So they're retroperitoneal, retro behind peritoneum. Most of the pancreas, probably about 80%, if not more, the pancreas is stuck to the backside of the abdominal wall, covered over by peritoneum. Small area, what's called the tail of the pancreas, a little tab at the very end underneath. It is actually behind the stomach on the far left side. side may stick out, but it's covered, and that would be covered all the way around with the peritoneum, but the majority of it, the body and the head and everything of the peritoneum, is covered over. The first portion of the small intestine, the duodenum, is stuck to the backside of the abdominal wall by the peritoneum, and frequently the ascending and descending colon are also stuck to the backside of the abdominal wall by the peritoneum. So some organs are actually retroperitoneal, meaning they're behind the peritoneum, okay? But that peritoneum lines everything else. And sometimes what happens is, just think about it. If I had that abdominal, all the abdominal organs, and they're all over the place, and they're just, and some of them, like the small intestine, moves around a lot. The transverse colon, okay, can move a big distance up and down, superiorly and inferiorly. And so what really holds them in there? I can't have a whole lot of blood vessels going all different directions. What actually brings the blood to these tissues, to these organs, is when that peritoneum gets to the backside of the abdominal wall, it comes together in two layers and comes forward. And when it comes forward, the blood vessels go between those two layers. It creates like a fan. Okay, and that fan then either connects various organs together, or it connects all that whole loop of bowel. I'll show you a clinical picture that shows you what it's like. And this is called a mesentery. And what sits inside, so the mesentery is basically two layers of the peritoneum, with inside, sandwiched between the two layers, are the blood vessels, such as the arteries and veins, as well as nerves. Nerve supply will go through there as well, because you can't have a whole lot of strands going of nerves and blood vessels going all over in the abdomen, because they'd just be, every time something would move, you'd rip one of them. So therefore it has to be held like that. Also, the transverse colon, I mentioned, moves a lot, because what holds the transverse colon to the backside of the abdominal wall is a large double band layer of that peritoneum that comes forward, so it creates a lot of motion and then wraps around the transverse colon as well. Also in the abdomen, I'll show you a picture of this, a diagram, this is in just a second, suspended from the inferior portion of the transverse colon is this large fatty apron, and this large fatty apron is called the omentum. It's actually where the peritoneum comes over the top of the large intestine, the colon, and goes down, and then two other layers come from the bottom and then go down, and they meet at the bottom. So that actually creates like 4 layers of this of the peritoneum, and embedded in those 4 layers of peritoneum is a bunch of fat. Actually, they could actually take, sometimes if they go up closer to the area of the transverse colon, they could actually go down inside there, and it's actually an extension from what's called the lesser omentum, which is behind the stomach. Okay, and that's a little bit more than what you have to know. But if I'm trying to show you what we're talking about here, and hopefully this isn't gonna, there we go. We have a bunch of pictures. I'll show you. Well, that first picture we lost, I have a better one coming up here. Here's one right here. This is actually looking inside the abdomen. If you'd cut open the abdomen, and you can see that the liver sitting right up there. You see something that says falsiform ligament. Falsiform ligament is part of the peritoneum that comes together, and it's like a band that goes through the liver that sort of helps to suspend the liver from the diaphragm on the top. So that's what this, so the liver is sort of like suspended by part of the peritoneum that comes from the top, is what we call the falsiform ligament. Okay, just underneath that you see where it says the stomach, and you see the transverse colon. And if you look underneath or inferior to the transverse colon, there's sort of like a yellow fatty material, and that's called the greater omentum. It's like an apron. You can actually take this, okay, and move it. Okay, it just comes down like in a big sheet, and I'll show you what the image would be like in a minute. A big sheet, okay? And it's interesting, they call this greater omentum the policeman of the abdomen, because what happens is sometimes if somebody has like a bowel perforation or an infection, they'll actually find that the greater omentum will actually migrate to that area and wrap itself around that loop of bowel to try to wall it off, so that it won't have a lot of pus moving in a bunch of different directions. So that actually is called the greater omentum, okay? If I look at another picture down here, is you can actually see where the greater omentum is gone, okay? And then you can see underneath that greater omentum, and again, you can just flap it up. Normally in surgically, they don't take it off. They leave it in there. They just fold it up, they flap it up, and they cover it with a wet towel. But below that, you can see these loops of bowel, which is down inside there, and that's the small intestine. The large intestine is that frame, that picture frame that goes around it, and you can see where the large intestine. If you see there in the bottom lower corner of that picture, you can see a little thing that looks like a little worm. That would be where the appendix would be, in the right lower quadrant. And that area on the bottom of the large intestine is called the cecum. We'll talk more about that in a subsequent video. And then we go for the ascending colon. So what happens is right there, the small intestine at the what's called the ileum empties through a little sphincter into the colon, and it's called the ileocecal valve or ileocecal sphincter, right where the ileum, which is the last portion of the small intestine, empties into the colon, and that colon, the area of the colon that empties into is called the cecum. Then what happens is they have to go upwards, okay, which is the ascending colon, which is usually stuck to the backside of the abdominal wall and maybe retroperitoneal, behind the peritoneum. Then we go across the transverse colon, which is freely movable, and there's actually that what's called the transverse mesocolon, which is two bands of the peritoneum. They're together, a flap that wraps around the colon in the front, okay? And that's called a transverse mesocolon. And then we have the descending colon, and then the colon then wiggles around, make a little S-shaped curve, which is called the sigmoid colon, until you finally end up with the rectum and the anus, okay? One thing I do want you to look at this picture here, though, is just below the liver and just above the area of the stomach, you see like a whitish band, okay? And that's called the lesser omentum, the lesser omentum. And what happens is that lesser omentum is still peritoneum that actually connects the bottom side of the liver with the top of the stomach. If you look at the stomach has a curve at the top and a curve at the bottom. The top curve is smaller, so they call it the lesser curvature. The big curve on the bottom of the stomach, or the inferior aspect of the stomach, is larger, so they call it the greater curvature. And what happens is this, the peritoneum connects as it wraps over the liver, folds back, and creates this membrane that goes down. It's again 2 layers from both sides that come together and goes to the superior portion of the stomach, and then it goes over the stomach, and it continues on. It will continue on as the greater omentum later on. But what happens if you also look at this lesser omentum, you can see on the bottom side of the liver a greenish thing, and that little greenish thing would be a diagram that would represent where the gallbladder is. And the gallbladder is actually stuck to the bottom side of the liver, and it's held to the bottom side of the liver. It's actually, there's some fibers, some connective tissue fibers that hold it to the bottom side, but it's also covered over by the peritoneum. The peritoneum covers over the bottom of the liver and covers over the gallbladder. But if you look where the little tag comes down, it looks like a little channel at the inferior portion of the gallbladder. That's called the cystic duct. And the secretions, the bile in the gallbladder, are secreted out through that cystic duct into the first portion of the small intestine called the duodenum. But if you look right below that, it looks like there's a little curved edge of that whitish tissue, okay? And that's actually a hole in the abdomen. It's called the epithelial foramen, or the foramen of Winslow. And what happens is you can actually go behind there and look inside, and behind there is where the pancreas is. So the pancreas sits behind that little hole, okay, back behind the stomach and that lesser omentum. So to be able to get to the pancreas, they actually have to get through that area, remove a lot of that stuff, and then get back inside to get to the pancreas. So it's not an easy thing to get to, okay? So anyway, that's just looking at another thing. And here's another picture of the abdomen. And what they've done here is they've sort of like taken an image where like they've removed or they pulled the small intestine out, and you can see all the loops of bowel on the left side of this image, but then you see sort of like a tan, shiny, flatter area that's in there, and that's actually what's called the mesentery, like we talked about before. That's actually where that peritoneum comes together in 2 layers, and the blood vessels are going to come through. Now I'm going to show you a better picture to show that a lot better in a couple minutes. Now this is actually looking at the peritoneum, a little bit better picture than the first one that we actually went past really fast and didn't get to see. If you look at the abdomen here, this is looking at the abdominal cavity, and it's on a sagittal or mid-sagittal plane cut, which you should have automatically been able to figure out. If you look at the blue line is part of the peritoneum that's along the abdominal wall, and that would be the parietal peritoneum that would follow those little lines. This would be a female because you can see where the uterus is, which is between the 3 and the 5. That brownish area between the 3 and the 5 would be the uterus, okay? So this would be female. Then you could see the blue line, which would be the parietal peritoneum. You can see how it follows along the backside of the abdominal wall, just in front of the vertebrae, comes down a little pouch. The little pouch where it says 5 is actually called the pouch of Douglas, or the cul-de-sac, or the recto-uterine pouch, because it's between the rectum posteriorly and the uterus anteriorly. Then the peritoneum covers over the top of the uterus, covers over the rest of the bladder that we can see, and comes up the anterior abdominal wall, goes up to the top of the liver if you follow it, and finally when it gets to the top of the liver, it folds back on itself. Now you see that color has changed from blue to pink or purple or whatever you want to call it. It covers the liver, comes in and covers all the other organs. You can actually see where it says 11. See, it comes down. That would be the area of the greater omentum, which is actually 4 layers of peritoneum that come down that way. And there's also like a little sac that's inside there. You can actually get inside there. All those little circles that you see, you know, like dangling from like little strings, those would be loops of bowel, and the loops of bowel would still be covered by the peritoneum, and all that purple would be called the visceral peritoneum, because viscera means organ, so it's covering the visceral, all the organs. Now, one other area I want you to look at, and you see where number 12 is pointing to something that's sort of like an oval thing that's open, that would be the stomach. That would be the area of the stomach that you would see there, okay, where like the number 12 is pointing to on the left image, okay? That's the stomach. And what happens is, if you look behind the stomach, okay, there's a little cross-hatched area, okay, cross-hatched area, and then a little circle, and inside that circle it says EF. Okay, EF stands for epiploic foramen. That was the hole that we talked about. That gets me behind the stomach. And if you look at the thing that's posterior to the stomach, between the stomach and the vertebrae, it looks like a little sponge area. That's actually where the pancreas would be sitting, right behind the stomach. And that crosshatch area is actually an open area. It's an open sac and filled with a little bit of fluid that's in there. It's not because it could come out through the epiploic foramen, but to be able to get back, to be able to do something on the pancreas, they actually have to go through and through that epiploic foramen, open that up to be able to get back to the area of the pancreas. The image on the right shows about the same thing, but just in a little bit of a different appearance of that image, where the purple or red would be the visceral peritoneum, where the blue would be the parietal peritoneum. Okay. Now this is just a clinical picture. If you can't see too much on the upper left, the one that with the up on the left, but if you look on the lower, on the one on the right, it shows a couple things. If you look around the outside, you can see the loops of bowel. Those are all the intestines that are around the outside of that. Okay, and that is the small intestine, and that's loop of bowel. But if I look at that middle portion, it looks like a fan. Okay, it's sort of like shiny and glistening. You can see it's sort of like the light shining back. That's the mesentery. Okay, that's the mesentery, and that's where the peritoneum is folded over on itself, where it comes in that double layer. Now, the reason why it's important, if I look particularly up in the upper left-hand corner and the upper right-hand corner, you see that loop of bowel there? You see all those red stripes and the darker stripes? Those are the blood vessels that are actually coming off what's called the superior mesenteric artery from the aorta to be able to supply blood through the, and those blood vessels are inside between those two layers of the peritoneum to be able to supply the blood supply to the entire intestine. Okay, so that's what we see, and that, I thought this was actually a pretty cool picture to show that. I thought that was pretty impressive to see that. Okay, so you see the loops of bowel on the outside, you see the mesentery, and you see a bunch of other stuff is just, I don't know what that is. It's probably where they cut it off, okay, where it's red. But if you look, you can see where all the vessels are, and you can see where that shiny area, which is actually that mesentery, and that mesentery is a double layer peritoneum that sort of holds the loops of bowel sort of together a little bit, but allows a route to get for the blood vessels to be able to get to the bowel. Okay, it's important. This just shows something else that's really, you know, we'll just tie this up real quick. If we look at what's you know, what goes through the gut, this is just looking at what's ingested and secreted and what's eventually eliminated. Okay, when we start to look at the GI tract, again, most of my fluid balance is not lost or not controlled in my GI tract. Okay, if I look at the saliva, you know, and these are just rough estimates, you might have a liter of saliva, you have about 1.2 liters of ingestion of fluids per day, okay, about 2 liters of gastric juice that the stomach's making, about 1 liter of bile, which is basically helping to emulsify or liquefy fats. You have some pancreatic juices, about 2 liters of pancreatic enzymes. You see some intestinal juice, another liter, you know, and then when we look at all that, basically we have about 8.3 liters of fluid that are going through my intestinal tract. But what happens is, when we finally get to the large intestine, the purpose of the large intestine for the most part is to remove most of that fluid. So I take that 8.3 liters and then take most of it away, you know, and what happens is you take it, you add another 0.9 liters of fluid. So now I have 9.2 liters, and basically most of it is going to be reabsorbed, and very little fluid comes out with the fecal material. Okay, when people have diarrhea, they leave too much water in the fecal material, and it comes out, more liquidy, more squirty. Well, the problem and the reason why that's like that is the inside lining of the colon becomes inflamed. And what does the colon or large intestine do? Absorb fluid. If something's inflamed, the membrane, instead of being very thin like we talked about with the layers before, the membrane becomes swollen and thick. When it gets swollen and thick, I can't get things through it. I can't absorb as much fluid. Sometimes there'll be a little membrane that'll form over it, or a little like, grungy material that prevents the absorption of the fluid. Therefore, the fluid is not absorbed in the colon, stays with the fecal material, and it comes out with more liquidy stools. Okay, so basically that's a little about absorption and secretion. Most of the stuff that gets in my GI tract eventually gets absorbed, and back into the system as fluid, as water. Okay, and then this little bit that's out creates more formed stools, more bulky type stools. Okay. So that's sort of tied up what we didn't get on that first one. So this one would be GI system 1B or something like that. And basically where it cut off on the first one, now we finished up here. So look at both of them to make sure you got them both. And it just talks a little bit about, how the abdomen sort of set up in regards to the various organs. Again, if you have any questions, I'm always free to be able to ask me any questions that you have. But we'll go on to the next part. We'll be talking about the upper GI tract, and we'll talk about the lower GI tract, and we'll talk about a little bit more about absorption and digestion and stuff like that in upcoming videos. Okay, talk to you a little bit later. Bye.